Thank you very much for inviting me, and I'm privileged to be here. And I've met many people who have trained and worked in Dublin, and in particular Case Elgawi, who works here. Case and myself go back many years with numerous publications, and it was great to meet up again. This morning I'm going to talk about pediatric penetrating keratoplasty. I have no financial interest. Pediatric corneal grafting was infrequently performed until the 1970s and was only recommended in children with bilateral corneal involvement, but obviously with technical advances and therapies, we've lowered the age and we've increased the indications, and we now use it in unilateral cases. It's a significantly lower success rate than in adults, and you can be a very good adult grafting surgeon, but doing graft surgery in children is a completely different ballgame. And the indications are obviously congenital opacities, in particular Peters anomaly, which is the big one, and there are a whole lot of other sclerocornea, and then there are the acquired problems. And these Peters anomaly is a heterogeneous group of conditions. It can be sporadic, it can be genetic, and about 80% of the cases are bilateral. And the big issue with it, of course, is that the association in many cases with glaucoma, which makes it the prognosis poor. And there are three groups. It's been classified by a lot of people, but basically you can have corneal involvement, corneal with the iris, and the lens involvement. And it's associated with a whole lot of systemic conditions, which in particular make the prognosis poorer. It's a challenging case. You've got the preoperative management in terms of the baby, the parents. You have the surgical challenge, you have the postoperative challenge. So it's an extremely challenging surgical problem. Patient selection is important, potential for vision, and this involves proper examination of the eye. And of course, you've got to bring the parents along with you, because you've got to make sure they know that the prognosis is very guarded, and that at best they may only get navigational vision. The operative procedure involves special considerations. You've got to drop the pressure in the eye, IV mannitol. And the surgical technique is far different, using the pharyngeal ring, how you manage the sutures, use of viscoelastic, and in all the cases I've ever done, I oversize the graft and I try and use young donors. Intraoperative challenge includes the decreased cell rigidity, the iris is more adherent, and you've got anterior segment abnormalities, severe wound inflammatory response, the management of the sutures, the management of the post-op and medications, and obviously amblyopia management becomes an issue. The postoperative care involves intense steroids, both topical, and I have always used cyclosporin 2%, and I've used it for over a year in most of these cases. This is an example of a Peters anomaly with the pharyngeal ring in place. And once you take off that button, the most frightening business is when you see the iris diaphragm coming forward. And of course, in unilateral cases, the important thing is to try and preserve the lens. In bilateral cases, not too bad, because you can make them bilaterally aphakic. And this is the management of the sutures. The usual rule that I use is 4 weeks per year of age, so the sutures come out at about 4 weeks. Important suture management is very important in all grafts, but particularly in pediatric grafts. And these kids heal up very rapidly. The sutures get loose and they get this reaction, so it's important to take them out. And these are just some examples of, like any procedure, lecture we show are good cases, but I've had numerous bad outcomes in terms of one case with a suprachoroidal hemorrhage. But there's been a number of good cases, 4 years post-graft. This is sometimes you're faced with. And the graft can be good initially, but then after a short time you get all the problems of graft failure and so on. And in some cases I've just gone through these quickly because these are some of the cases I've seen over the years that I've had to graft. And in some cases I've used keratoprosthesis, again bringing its own problems, post-graft membranes. You have to use a contact lens in the eye. They are on antibiotics indefinitely. And of course the other added problem you have in these kids is you can't really adequately check their intraocular pressure. And these are just cases that I have to flick through because time constraints. But basically, these are the ones we've seen over the years, and I've grafted many kids, and I've had, as I said, lots of failures, but quite a few successes as well. So it's not something that you give up lightly on. And this is a child, I've just shown the pictures now, sometime later, another child here, another one at 6 years post-graft, and I have a child over 20 years with bilateral clear grafts. Again, the use of K-Pro can be used in these cases. Additional procedures, obviously, the loss of the crystalline lens in bilateral cases, not too bad. And you've also got to think of the use of a valve insertion at the same time. Acquired traumatic and acquired non-traumatic are much easier to deal with. One of the issues that I've now used in recent times is I cross-link all children once I diagnose keratoconus, so this will eliminate grafts in the future. There's a child with CHED, congenital corneal endothelial dystrophy. These kids I don't graft until they're older, and these are kids now that are useful to have an endothelial graft done on them when the chamber is deeper. Publication with Shiraz Dye and East Grinstead and myself many years ago, where we put our cases together. Survival about 61% at 12 months, and 10% of them were repeat operations, and 7 subsequently failed. Other studies, Stutling, French Brown, all these people have published cases, 65% at 1 year. And the important thing here is that the majority of graft failure occurs within 26 weeks of the surgery. And so this is important. So the first year is very important. And obviously, if you have the second failure is going to fail more often, and the third one is again is likely to fail, more likely to fail. And what I could say is this is a procedure with huge risk of failure. Obviously, they require careful selection, optical correction, post-operative management, including amblyopia, and you can get improved visual outcome. I think they require early surgery. The outcomes in many cases are poor. Amblyopia, graft failure, astigmatism, and other ocular pathologies make the prognosis poorer. What are the alternative options? Obviously, you can do, if you can do optical iridectomies. At best will give you navigational vision. And in some cases, this may be the best option rather than doing all this more big, high-powered transplant surgery. The goal, of course, is to maintain a clear graft, reverse the amblyopia. And what I can say to you is that penetrating keratoplasty is a difficult and challenging procedure, but the outcomes have significantly improved. Thank you very much.